Good morning, welcome to In the Trenches with DAC. Today I'm going to talk about hypercalcemia. This is not an uncommon electrolyte disorder that we see both in the inpatient and outpatient venue. To approach hypercalcemia, you need to understand pathophysiology. There are two arms here. There's the vitamin D arm and there's the PTH arm. So let's talk about vitamin D. Vitamin D we get from the sunlight and to a lesser extent from some foods. Okay, sunlight activates vitamin D2 to vitamin D3. It goes to the liver, it becomes 25 hydroxy vitamin D3, and then it goes to the lungs and it becomes 125 dihydroxy vitamin D3. The enzyme here that does this is angiotensin converter, is 1-alpha hydroxylase rather. This form of vitamin D is about 10% as strong as this. It still does what this does, but it's much, much weaker. Vitamin D does two things. It mobilizes calcium and phosphate from bones, okay, and it increases absorption of calcium from the GI tract. We absorb calcium in the duodenum. As a whole, we absorb about 35% of what we eat. It gets absorbed. Say we eat taking 1,000 grams of calcium a day, which is a little on the high side. In the colon, about 150 to 200 cc's are secreted into the bowel, and the rest goes into the urine. A normal 24-hour urine calcium is somewhere between 50 and 200 milligrams per 24 hours. Okay, but the major effect of vitamin D is to the GI tract by activating the enzyme 1-alpha hydroxylase. Two things stimulate this enzyme. Number one is a low phosphorus, and number two is PTH. That's the vitamin D arm. Now let's talk about parathormone, which is released from the parathyroid gland. Okay, parathormone does three things. Bone stimulates 1-alpha hydroxylase. And renal. Okay, so what we'll do in the bone, it will mobilize calcium from the bone. And if you have too much PTH, you're going to have osteoporosis, and you can have osteitis fibrosa cystica. Okay, it stimulates 1-alpha hydroxylase, so parathormone indirectly causes vitamin D absorption. Now at the kidney, it works two places, at the proximal tubule and at the distal tubule. At the proximal tubule, it decreases the absorption of phosphorus, sodium, bicarb, and actually to an extent calcium, but at the distal tubule, it increased reabsorption of calcium. So you have too much PTH, you're going to have a low phosphorus, you're going to have essentially a type 2 or proximal renal tubular acidosis, but the calcium is elevated because you work to resorb it distally. These are the two basic pathophysiologic arms. Now, let's go over the etiology of hypercalcemia. It used to be that people with hyperparathyroidism, which is the most common cause of hypercalcemia, it used to be that these patients presented with advanced disease because nobody was monitoring calcium. And then around the late 1970s, they started having these blood profiles, chemistry tests. Initially they called them SMA-12s. And they noticed a lot of people had elevated calciums, and they were asymptomatic. And the calciums may not have been that high, but it turned out to have primary hyperparathyroidism. So let's go through the etiology. The number one cause is hyperparathyroidism, primary hyperparathyroidism. Okay, and this could either be due to solitary adenoma or four-gland hyperplasia. Next thing is malignancy. Now this is complicated because there are different mechanisms of malignancy. The classic one people think of related to something called humoral hypercalcemia malignancy, which is involved with something called PTH related protein. So the PTH levels will be low, but it has some similar factors to PTH, especially low phosphorus. The tumors that do this are basically the squamous cell cancers, especially lung, esophagus, head and neck. So these are smokers. And then GU tumors, especially renal. Okay, the next category is direct bone mets. A lot of tumors that could metastasize directly to the bone. It's a common source, lung and breast, causing hypercalcemia. Next thing is something involving rank ligand. Now, they used to call this OAF back in the day, osteoclastic activating factor, where it was a chemical released by the tumor, and it caused calcium to be sucked out of bones. And the classic tumor that does this is multiple myeloma. You could also see this with adult T-cell leukemia, lymphoma, but that's more unusual, and that's due to HTLV1 virus. And the fourth, and this is not common, but you may see it, is due to increased vitamin D toxicity, due to increased 1-alpha hydroxylase, due to granulomas in the tumor causing this release. And the things that do this are the lymphomas, Hodgkin's, non-Hodgkin's. Okay. Next thing you have to think of are granulomatous diseases. Okay, and the classic one is sarcoid, but you can see it with TB, with certain fungal infections. They reported it with a bunch of things, but the granulomas secrete 1-alpha hydroxylase, and they cause calcium absorption through the GI tract. And this is something, you will see this with hypercalcemia, with sarcoid. And you may see this with other disorders. Sarcoid's the primary one. Initially, they get hypercalciuria, and they could get kidney stones, but they could also get hypercalcemia. Something else to think of is thyrotoxicosis. Sometimes people miss this. Excess T4 will cause calcium resorption from the bone. Okay, let's go through some other things that need to be on the list. Vitamin D toxicity. Now, this you will say it's not as common. These people have increased 25 hydroxy D3, and they take so much of it, it causes hypercalcemia. In theory, vitamin A toxicity could do that also. I've never seen that. The milk alkali syndrome. So if someone's taking a non-absorbable antacid, they have a metabolic alkalosis and hypercalcemia, you have to think about this. This you may see. Immobilization. Not most people, but people with active bone turnover when they're immobilized. So an adolescent, whose bones are growing, active bone turnover, or somebody, an adult, especially an elderly person with Paget's disease. These people could be at risk for that. There's something called familial hypercalcemia, hypocalciuria. It's familial autosomal dominant, where the bar for releasing PTH is lower. And these people, they have end organ resistance to hypercalcemia, and they have a low serum calcium, and this is not usually that significant. There are other things on the list that, you can have the recovery phase of rhabdomyolysis, could do this. You get something called the tamoxifen flare, where a person with metastatic breast cancer, initially when they're placed on this, it causes calcium to leak. Certain medicines, the two medicines you need to be aware of are thiazides and lithium. So you need a medication history, especially thiazide diuretics. They need to be on this. One thing you need to think of, if somebody's very dehydrated, they may be hypercalcemic, and that may respond to fluids. And if you look at mnemonics and textbook lists, Addison's disease is on that, probably on the basis of volume depletion, unless it's associated with primary hyperparathyroidism. So there may be a few other unusual causes, but I'm going to put this as the list, and I'm going to give you a mnemonic. So the mnemonic I learned was something called Pam Schmidt. So if you get pimped on rounds, and they ask you to rattle off cases of hypercalcemia, you can think of this. So P is parathyroid. A is adrenal insufficiency, not common. M is malignancy. S is sarcoid. M is myeloma. I is immobilization. D is vitamin D toxicity. And T is thyrotoxicosis. Okay? So I'm going to just quickly, in the last couple minutes, talk about a basic guide to treatment. Okay, you can hit two things. First, part one is calciuresis. You need to get calcium out, and then you have to affect the osteoclast. So with calciuresis, you're going to give fluid. You're going to give normal saline. The more sodium you give, the more more calcium you will put out. Often these patients are mildly volume depleted anyway. A loop diuretic may help, but you have to be euvolemic. Loop diuretics like Lasix will prevent calcium resorption at the thick ascending limb of Henle's loop. But you need to be rehydrated. So the key here is normal saline. And then working on the osteoclast, which is the main, and the drugs here are really the bisphosphonates. And the big one here is the big ones are either pimidronate or zoledronate. Drug that's sometimes used is calcitonin. You develop calciphylaxis to this. This initially causes calciuresis and then it affects bone. These are the major things. Sometimes steroids are used. Steroids could be used for breast cancer, for sarcoid, or for myeloma. So there's special indications. There was an old drug called mithromycin. It's a chemo agent that was used, and it kills osteoclasts. It was a chemo agent. When they gave it, the patients became hypocalcemic. But it has too many side effects, and that was more a drug that was used back in the day and not used now. So in summary, with hypercalcemia, when you pick it up, now somebody's really, in the hospital, they could be symptomatic from it. Initially, it'll start off, you could have GI side effects, constipation, nausea and vomiting, but as the calcium goes up, patients could have neurologic defects and they could really become obtunded. And usually the hospitalized patients have very high calcium levels. If this is picked up in the outpatient venue, more often than not, it's due to hyperparathyroidism. So when you're working this up, the first test you need to do is get a PTH and impact assay. If this is elevated, it's hyperparathyroidism, possibly medication-induced thiazides or lithium. Okay, if it's low, it's something else. Okay, and then you need to go through the differential. You may get protein studies to evaluate for myeloma, a chest x-ray, thyroid function test, a 125 dihydroxy vitamin D3 level, maybe a 25 hydroxy vitamin D3 level, and you use that and you continue your evaluation subsequently. I'm going to sign off right now. We are in the trenches.